Let me now welcome Dr. Barbara Burton. She is a professor of pediatrics at Northwestern University Feinberg School of Medicine and director of the MPS and ML treatment program in the Division of Genetics, Birth Defects, and Metabolism at the Ann and Robert H. Lurie Children's Hospital in Chicago. She is board certified in pediatrics, clinical genetics, and clinical biochemical genetics. Her clinical and research interests are focused on inborn errors of metabolism and newborn screening. Dr. Burton is an investigator in numerous natural history studies and clinical trials and new therapies for various metabolic disorders, including the MPS disorders. We welcome Dr. Barbara Burton.
Thank you. Thank you so much, Terry. And I really want to thank you for inviting me to participate in this meeting. It is really such an incredible pleasure and a privilege. I wish I could see everyone in the audience in person and have a chance to chat with you. I always enjoy that so much at our in-person meetings, but I'm really grateful that we have this technology that allows us to get together virtually, and certainly am happy that we have so many people who've taken advantage of it today. We're talking today about one of my favorite topics, newborn screening, and also I'm talking to my favorite audience, which is patients and parents. I spend a lot of time talking to other health professionals, but this is really what I enjoy the most. So I want to share with you a little bit about what's going on in newborn screening for the MPS disorders. Here you see my disclosures. As you heard, I am involved in a number of clinical trials and also consult with a number of pharmaceutical companies. So let's first start by talking a little bit about what newborn screening is. Not everyone who's a parent is aware that every baby born in the US, and in fact in all of the developed countries, before they leave the hospital, is tested for a group of conditions for which early intervention, early treatment is important and can change the outcome. Some of those tests are bedside tests that are done, like hearing screening or oxygen testing, which detects some of the forms of congenital heart disease. But most of the tests are done on blood, and they're done on a blood sample that's collected by a heel prick on the baby that's usually done at about 24 to 48 hours of age, with the blood then spotted onto filter paper like you see in this picture. There's so much going on, I think, when you have a new baby in the hospital, so many classes, and you're told so many different things that a lot of times this just slides by people. They may not be aware of it, and certainly aren't always aware of all the conditions that are included in that testing. Many people still refer to this test as the PKU test because there's a genetic disorder called PKU, or phenylketonuria, which was the first disorder for which we had widespread newborn screening back in the 60s. But now in every state, babies are tested for over 35 different conditions, in some cases 50 to 60 conditions or more. And the way newborn screening works is that it is what we call a state health department initiative. Each state decides for themselves which disorders are going to be on their own newborn screening panel. And the blood testing is typically done in the state health department laboratory. There was for many years tremendous discrepancies between states in terms of which disorders were included, and babies could be born 30 miles away from one another, one in one state and one in another, and have a vastly different experience in terms of which disorders were included. So there was huge inequities in that approach. And as a result, sometime back, a committee was established at the federal level called the Secretary's Advisory Committee on Heritable Disorders and Genetic Disease in Infants and Children, which makes recommendations to the Secretary of Health and Human Services regarding which disorders should ideally be included in newborn screening. And those disorders are listed on what is called the Recommended Uniform Screening Panel, or RUSP. Most states follow federal recommendations and guidance, but they are not required to do so. It's not mandatory, it is advisory. And states can also choose to screen for conditions that are not on the recommended uniform screening panel. Currently, there are 35 disorders on the RUSP, including one MPS disorder, MPS I, which was added in 2016. There is also an established mechanism for nominating new disorders. Really, anyone can do it. An individual could do it, a group of physicians can do it, an advocacy group can do it, and MPS II was nominated this year for inclusion on the recommended uniform screening panel by the National MPS Society. It usually takes about a year for a new recommendation to work through the system, to be considered and studied and then acted upon by the committee. So we won't know anything immediately, but of course we're all very hopeful that next year at this time we might have a recommendation to add MPS II to the recommended uniform screening panel. Now, there's some general requirements that are usually there to tell us what is a good disorder for newborn screening. What's an appropriate candidate? Because of course there are hundreds and thousands of different conditions, and we don't need newborn screening for all of those. In some cases, when we make a diagnosis, we can treat a condition appropriately. But with newborn screening, generally speaking, we want to be talking about a disorder that's serious. There has to be a test, of course, that you can use in newborn screening to diagnose it on the dried blood spot. And you want it to be a test that is pretty sensitive and specific. You want it to detect almost all of the cases, hopefully all of the cases, without also pulling in too many babies who are unaffected with the condition, who then are subjected to further testing, so-called false positives. We'd like to have a test that doesn't have too many false positives. We also need to have a treatment. There needs to be something we can do once we recognize that a newborn has that condition. And we want to have evidence that giving that treatment, using that treatment prior to the time when we would normally diagnose the condition clinically is beneficial. So there has to be an advantage to early treatment. Otherwise, we could just go ahead and let the condition present, diagnose it, and then treat it at that time. And for the committee at the federal level to add a disorder to the RUSP, there always has to be some pilot data, ideally from the United States, showing that screening can be effectively accomplished and it can be done, can diagnose a case, and it can be integrated into our U.S. public health system. So why newborn screening for MPS disorders? Well, of course, I think MPS disorders are really ideal candidates for newborn screening. If you listened as I went through that list of criteria previously, you know they're serious. You know early treatment is important. You know frequently there's a long delay in diagnosis. So the benefits of newborn screening for MPS disorders include the fact that you can avoid the diagnostic odyssey that's experienced by so many patients and families, where they go from doctor to doctor with different symptoms and complaints. Oftentimes parents know there's something wrong. There's some reason why this one child has all these things going on, but it really takes time because of the rarity of the conditions for physicians to put it all together and get an accurate diagnosis. And we know with the MPS disorders, and we just heard it from Dr. Munzer, that early institution of treatment is important before irreversible and permanent damage occurs. We know that preventing symptoms is much easier than reversing them once they become established. So we know early diagnosis is important. And another benefit, of course, of newborn screening, and I hear this from families a lot, is that it gives them the information that they need to make decisions about future family planning. Sometimes what we see with disorders like this is that we may make a diagnosis in a child who's 3, 4, 5 years of age, and already there are 1 or 2 younger siblings in the household, and some of those younger children turn out to be affected as well. Whereas with newborn screening, of course, parents can receive genetic counseling, information about their reproductive options, and make informed decisions about their future family planning. So really, the MPS disorders meet all of the criteria to be good candidates for newborn screening. They're serious, certainly. There are tests available for most, if not all, of these conditions that can be performed on the dried blood samples. We know, and we heard again from Dr. Munzer, that treatment is available for MPS I, II, 4A, 6, and 7, and investigational therapies are being explored for many of the other disorders. And certainly there is some evidence, although we'd like to gather more, that treatment of the disorders prior to clinical recognition is beneficial. We all know that intuitively. I mean, physicians who take care of MPS disorders know that that's true, and we've anecdotally seen it, but we need to get more hard evidence into the literature. Now, pilot data from the state of Missouri were really instrumental in getting MPS I added to the RUSP. As I mentioned, we have to have some sort of pilot data to convince the committee that it works and it can be done. And that means that somebody's got to do it before it's on the RUSP, right? Because that's the only way we get it on the RUSP. So fortunately, we have the state of Missouri that was the first state doing statewide newborn screening for MPS I, and that provided a lot of the data for that application. Similarly, with the application for MPS II, we now have data from both Illinois and Missouri, the 2 states that are doing currently statewide newborn screening for MPS II. Newborn screening for MPS I, the disorder that is on the RUSP, is now becoming widespread in the U.S. It hasn't extended to every state. I'll show you the map in just a moment. It's also ongoing in some other parts of the world, including Taiwan, which has been a country that has been very much at the forefront in adding new disorders to newborn screening. And newborn screening for MPS I, and really for any of the MPS disorders currently, is done by measuring enzyme activity. So it is specific to the one MPS disorder that you're trying to diagnose. So for MPS I, the measurement is of the iduronidase enzyme activity. And there's several different ways in the laboratory that this can be done, and states can choose to use one or the other of these depending on the specific circumstances in that state. They work, all of them work. As the technology is improved, it may be possible to use measurements of GAGs in the dried blood spot as a primary screening tool. Right now it's not. You can measure GAGs in the dried blood spot, and you would think, ideally, this would be a great way to screen for MPS disorders because you should be able to find all of them, right? I mean, it would be fantastic. But fortunately, right now, with the screening for MPS, there are many, many false positives. So it's not really an efficient primary screening tool. However, it is being used as what's called a second tier test or a secondary screening tool in some states, so that once the enzyme activity is low, they do the second test using the dried blood spot GAGs. Now here is what I think is the current MPS I newborn screening map in the U.S., but this really changes all the time, because in addition to the states colored in red here, which are the ones that are currently screening all newborns for MPS I, there are other states that are in pilot phases, getting ready to do it, or have legislation or have made the decision to do it. So other states are coming online, but the states currently involved in screening all newborns probably account for about 2/3 of the babies in the U.S., because we have many of the high population states here, like California, New York, Florida, and so forth. Texas is one that's missing, and we need to get on there, but we really need all of them on there, right? And, you know, as I told you, this was added to the RUSP in 2016. It's 2020. Pretty soon it'll be 2021. So take a look if you're listening, and particularly if you are motivated with regard to MPS I, see if your state is on there. And if not, try to find out why not. So say you are in a state that's doing newborn screening for MPS I. I mentioned that it's done by enzyme activity. What happens after there's a positive screening test? Well, typically what happens is initially is the same thing that happens if any of the many tests done on the newborn come back positive. The physician is notified, and then the parent gets a phone call saying that there's a positive newborn screening test. That's always a phone call that is etched in memory forever. I don't have a single patient who's had a child with a condition detected by newborn screening who doesn't tell me that that telephone call was like life-altering. It was devastating and frightening and scary. And so there are some things you should know if a phone call like that comes in. And one is certainly that a positive newborn screen for MPS I, like a positive newborn screen for almost any other condition, does not necessarily mean that the baby has the condition. It means that the baby needs to have further testing. And that further testing is typically a repeat measurement of enzyme activity, but in a whole blood sample drawn from a vein, urine GAG determinations, and also molecular testing to see if there are mutations in the iduronidase gene. And this applies to those states where the only thing done in the newborn screening lab is the enzyme activity, which is most but not all of the states. There are a few states where they do the genotyping or they do the dried blood spot GAGs, as I mentioned. So what else could cause a positive newborn screen other than the baby having MPS I? Well, other things can certainly do that. One is that the baby could be a carrier of MPS I. Sometimes we pick up carriers who have low enough enzyme activity that they're picked up on the screen, but carriers don't have clinical disease. There's also another condition that's actually quite common called pseudodeficiency. And what that means is that the baby has low enzyme activity, in this case for iduronidase, if we're talking about MPS I, low enzyme activity typically on the dried blood spot, also when you measure it in a whole blood sample, but they do not have clinical disease. We know there are many babies picked up through newborn screening who have this situation of pseudodeficiency, and it's so important. I'm going to mention it a little bit more as we go on to the next slide. But if a baby is diagnosed with MPS I, through the further testing, through doing the urine GAGs, which are elevated, again, the enzyme is going to come back low again when measured in the blood. Then the next step is to try to determine, is this the severe form of MPS I, the Hurler form, or is it a more attenuated form, to determine the appropriate treatment, right? Now, many times this can be done by looking at the genotype. We know there are certain genotypes with MPS I that always confer a severe phenotype, others that are associated with an attenuated phenotype, but it is not always possible through the genotype. So in some cases, it may require careful clinical assessment and follow-up by the physician to make that determination. But once that determination is made, those babies who have the severe form can be referred right away for hematopoietic stem cell transplantation. And most of the babies across the country being detected by newborn screening with the severe form, and that's most of them, it's much more common than the attenuated form, they are having transplants prior to 6 months of age. And this is going to significantly improve the outcome. We have the data that tells us that the age at which transplant is performed is a very important predictor in terms of the later cognitive outcomes. So this is really a huge advantage for these babies. If a child is predicted to have the attenuated form, then of course they could be started on enzyme replacement therapy. So a couple more words about pseudodeficiency, because I've actually over the past year or so had a number of calls from parents whose baby had pseudodeficiency for MPS I in various parts of the country, but where there was a lot of confusion about what this means or what should be done. And as I mentioned, what pseudodeficiency is, it's a situation where there's certain changes or variants in the iduronidase gene that lead to very low enzyme activity as measured in the laboratory. Sometimes it's a little bit higher than what we see in the disease, but it can be just as low in that test tube as what we see in babies who truly have MPS I. But in the body, clearly these variants result in enough enzyme activity to prevent any accumulation of glycosaminoglycans and any clinical disease. Patients with pseudodeficiency never develop findings of MPS I. And it's a situation that in our country, in the US, is very common in African Americans, much more common than true MPS I. But it does occur in all racial and ethnic groups. But it happens that there are certain variants in the gene that lead to this pseudodeficiency situation that happen to be very common in the African American population. We know what many of those are now, so that when we do genotyping and we see them, we know that this is the explanation. And again, as I said, these babies also will have normal GAGs on the dried blood spot and in the urine. So they can be sorted out. And if you have a situation like that, you don't need to do anything. I mean, the baby doesn't need any further follow-up. They definitely don't need any kind of invasive testing, any X-rays, any MRIs. Transplants should never even be talked about in the context of pseudodeficiency. So after newborn screening, there's some very important things that have to be determined by the consulting physician, before there's any discussion of potential treatment, because many babies with a positive newborn screen will not need it. Now, there are situations with newborn screening for MPS I where things are not so clear-cut. I mean, most of the time we can determine, yes, this is MPS I definitively, figure out the phenotype, or we can decide this is pseudodeficiency, or we determine it's a carrier. But sometimes we encounter situations where things are not so clear. Maybe our urine GAGs are borderline and we need to do a repeat down the line, or maybe our genotype is not clear cut. There's some novel variants seen that are not known to be pseudodeficiency variants. They're also not known to be associated with MPS I, where we have to do some thinking and some follow-up. And in those cases, repeat evaluations and repeat urine GAGs over time may be necessary to really get the situation sorted out. But in those cases, that certainly can be done. Second-tier testing, like I mentioned, is used in some cases in MPS I newborn screening. There are a number of states that use this. One state that's published some of their results is Kentucky, where their testing is actually sent to the Mayo Clinic, and the testing is done at the Mayo Clinic. And the screening is done by measuring enzyme activity, just as it is in all states. But if the enzyme activity is low, then dried blood spot gags are measured as a second-tier test. And they reported in their early screening experience that out of over 130,000 infants screened, only 2 positive screens were reported where both the enzyme was low and the dried blood spot gags were elevated, and one of those had MPS I and one was a carrier. So it's really very effective in screening out all the pseudo deficiencies and screening out false positives, but still there are, I think, some unanswered questions. One that we can't answer definitively is, do all patients with attenuated forms of MPS have elevated gags in urine and in dried blood spots at birth? We know they have elevated gags when we diagnose them clinically later in life, but we don't really have very many specimens. Very few have been analyzed from attenuated patients with MPS I or even MPS II, when we get to that, who had samples available, from the dried blood spots or urine samples from the time of birth. So we think the answer is probably yes. They're probably elevated, even in the attenuated patients. But the evidence thus far is a little bit sparse and really not sufficient to conclusively say that that's going to be the case. And the risk is that if they're not always elevated, then we may be missing patients if we use gags as a second-tier test and we eliminate those patients from any further follow-up, or even in the clinical setting if we use urine gags and say that this is a patient who's unaffected. Could there be a risk of missed cases? So hopefully over time, with more experience, we'll feel more confident about that, but that's a little bit of an uncertainty right now. So let me move on from MPS I and say a few words about MPS II newborn screening. That also is currently ongoing in Taiwan and has been for a number of years. In the United States, there are 2 states who are doing ongoing screening on every newborn, and those are Illinois and Missouri. We started in my state, which is Illinois, in December of 2017. And as of February of this year, 339,000 plus infants had been screened, and we had identified 3 affected infants. We also found that pseudodeficiency also occurs for the MPS II enzyme. It's not as common as with MPS I. It is more common in the Asian population, seemingly, than in other populations, but we do see it in all racial and ethnic groups. We know now some of the common pseudodeficiency variants that have been reported from Taiwan and Japan, from Asia, and we see them in our Asian American patients also. But we also do see novel variants that we are assuming reflect pseudodeficiency when we see a normal baby with normal urine gags, but one who has low enzyme activity. In addition to the 3 patients out of this 339,000 that I mentioned as of the end of February, when I had full data, I can tell you that we've had 2 more babies with MPS II diagnosed since that time. They've both come to our center. So there have been 5 babies in Illinois who've had the incredible benefit of diagnosis shortly after birth. It warms my heart. I mean, I feel like it's so important, and I think their lives are going to be so different because of it. I think, the outlook for them is so much better that I want to see this extended to all babies. What about newborn screening for other MPS disorders? Well, it's possible. I mean, the tests are there for the most part for many of these. There is testing going on for a number of other MPS disorders in Taiwan, MPS IIIB, 4A, and 6. There's screening for MPS 6 in some high-risk communities in Brazil. It is possible to combine screening for some of these MPS disorders in some of the same testing setup that is used. So hopefully over time, some of these less common disorders can also be included, because certainly you can argue that they will benefit in very much the same way as our patients with MPS I and II. So what can families do to promote newborn screening? I would say that if you looked at the map and you saw that your state is not yet doing MPS I newborn screening, it's on the RUSP, and they're not in the process of implementing it, that you should find out why not. Talk to your state Department of Health. Most of them have a genetics program or a newborn screening program. They all have a website. You can look up newborn screening in whatever state. You'll find the website. You'll be able to find someone you can contact to find out what's going on. I mean, what's the holdup? Find out also, let's say you're an MPS II family, you know, and you feel like it's not fair that babies in Illinois and Missouri have the benefit of newborn screening for MPS II. Why shouldn't babies in California have that same benefit? There's a huge inequity there. Find out how in your state new disorders can be added to the newborn screening panel. Sometimes the Department of Health can just decide on their own to add a new disorder. Some states are bound by law to follow the recommendations on the RUSP, and in some states they have a certain time period in which they need to implement any new disorder on the RUSP. But they need some oversight, if they have that, to make sure they're actually doing it and doing it in the right time frame. Sometimes legislation is passed in an individual state. In my state of Illinois, for example, the health department can decide on their own to add new disorders administratively. Legislation is not required, but they're not a particularly proactive health department, and we still wouldn't be doing LSD screening if we had relied on that. The reason we have screening for 7 LSDs in Illinois is that legislation was passed, and that legislation was spearheaded by patients and families. Legislators listen to constituents, and it's amazing the power that an individual patient or family can have when teamed up with a motivated legislator. So if that's something that you're interested in doing, absolutely go for it. I can tell you that there's a disorder not on the RUSP, but another lysosomal storage disorder called Krabbe disease, where patient advocates have been very active, and there's 10 states now with legislation mandating newborn screening for that disease. 8 of them are up and running, and the other 2, and they're moving into other states the same way. So you can move ahead of the RUSP. And we wouldn't have a prayer of getting MPS II on the RUSP if we hadn't had states that started to give us that pilot data to get it there. So if you're involved in any of these activities, or maybe you're concerned what's happening with MPS I, find out, you know, when your state newborn screening advisory committee is meeting. Virtually every state has one that advises the Department of Health. They're typically all open meetings. Now they're probably virtual, of course, but patients and parents, citizens, anyone can attend, and there's typically a way that you can make comments. So attend the meeting, speak up, you know, make it known that this is something you want, that's important, and that somebody's watching to see that they do it. And again, you know, legislation is another option. So to summarize, I'll just say that newborn screening for MPS I is becoming widespread. It allows treatment to be initiated at a very early age, really improving outcome in the disease and avoiding the diagnostic odyssey. Newborn screening for MPS II is beginning and hopefully soon will become more widespread. Screening could be done for all of the other MPS disorders. The technology is there. I think over time we're going to see it more and more. And importantly, families have really been the impetus, the main impetus for initiation of screening where it is occurring and can really be powerful advocates for moving this forward. So again, thank you for letting me participate, and I'll turn the microphone back to our leaders.